you guys have asked for a review of acetaminophen dosing from Pathopharm 1.
Is this all in the text?
It could be.
All right.
I don't know. I don't know why you guys are asking for it. I just know you asked for it, so we're going to do it.
Do I need to?
So the key to remember is that anytime you are administering acetaminophen, in addition to the time limit on the order itself, you also have to take into account how much acetaminophen the patient has received in the last 24-hour window. So will this next dose that you're about to give put the patient over that threshold? So let's imagine for a moment that you have two orders. You've got one for APAP 325 milligrams, 2 tabs, PO, Q 4 hours, PRN. And then you've got Percocet. Um, 5, 325, 2 tabs, PO, Q, 4 hours. All right, so tell me what's happening with this patient.
You're getting Percocet every 4 hours, 2 tablets, for sure. And then as needed, they can take acetaminophen.
Okay. So, and as needed, they can take acetaminophen, and how many can they have there?
2 times every 4 hours.
Okay. Now, what I want you to do is tell me how much acetaminophen this patient's going to have by taking that Percocet in a 24-hour period.
650 times
650 times 6. What is that?
Oh no. 3,900.
Okay. So, with just this Percocet order, that patient is going to be taking 3,900 milligrams already. So they'll never be able to take the acetaminophen dose with that. So just be aware, if you ever see this particular pattern, you need to tell that physician. Okay, you could do either of these. So if the patient's like, yeah, I don't really need the Percocet, then they can have the acetaminophen instead. But this is not really an as needed along with this schedule. If they were both PRN, then you could interchange one drug for the other one. Does that make sense?
Percocet is acetaminophen oxycodone.
Yes. Okay, so with this particular pattern, it's a little funky. So let's change this now and make it 1 tablet every 4 hours. So patient came back from surgery and they got their first dose yesterday at 1,400 hours. So they got Percocet, and then 4 hours later was 1,800, and they got Percocet, and then 2,200 hours, they got Perc, and then at 0200 in the morning, you woke them up and gave them Perc, and then at 6 in the morning, they got Perc. All right. Then they woke up at 3 in the morning. And they asked for pain medication and they got APAP. So the time is currently 0900. And your patient is asking for pain medicine. What do you do? Okay. So At 2 o'clock, at 1400, they got 650.
Wait, I thought it was one time.
No, one tablet.
Oh, sorry. Yep, you're right. So they got 325, 325, 325, 325, 650, 325. Now, it's 9 o'clock. Can you give them Percocet?
Yeah.
No.
You can give them acetaminophen.
Okay. When are they getting the next Percocet? At 10. So you can't give them the Percocet yet. They got to wait another hour. Okay. So, can you give them APAP here? If you give them 650, what will that do to their total dose of acetaminophen? Add all those up. What happens?
2,925.
Say again?
2,925.
2,925. Okay, so they can have that safely, no problem. Now, it's 10 o'clock. It's time for their Percocet. Can they have the next dose of Percocet if you give them this acetaminophen?
Yeah.
Are you sure?
What's the rule with this again? I don't
No more than 4,000.
Yeah, you can.
Yeah, if this dose is going to put them at 29,000, then, or sorry, 2,900, adding another 325 at 10 is only going to put them at 3,300-ish.
Yeah.
Yeah, 3,250. So, yes, they can safely have that, and it won't affect their 10 o'clock dose. So that's basically how you do it. Any questions? All right. Now let's go home. All right, but you guys have chosen the way of GI. When this thing runs out, I'm going to be sad because this is a great color. This color goes great with my lips. All right, welcome to the Gastroenterology lecture. We're going to start off with upper GI. So that is going to be the stomach and everything above the stomach. And I guess technically the duodenum as well. So we're starting off with the esophagus. So with the esophagus, there's several things that can happen. Well, actually, I guess first we'll start off with the throat and then a little bit less the esophagus. So I'm going to start off with dysphagia with a G. So dysphagia is difficulty swallowing. And there's a number of reasons why a person can have difficulty swallowing. Name a couple. Okay, well, the big one is a stroke. So the sequela from a stroke can cause neurological damage. All right, what else?
Allergic reaction.
Allergic reactions. Patients who have allergies can sometimes have trouble swallowing. What else?
Choking.
Okay, an obstruction. All right, what else?
Swelling.
Okay, swelling, allergy, yeah, okay. What else? What else you got? Decreased level of consciousness. Mind-altering drugs. So, patients who have had surgery, recovering from surgery, patients on opioid pain medications, are at risk for dysphagia. Any type of neurological disorder that can affect the mouth and throat is also a potential. And of course, the big one there is stroke. Now, someone said obstruction. And one of the major obstructions is called achalasia. So, the esophagus comes down, and then here's the stomach. Right at the stomach, there is a sphincter called the lower esophageal sphincter, or LES. What does LES stand for?
Lower esophageal sphincter.
Don't you like how I just make you repeat what I just said? Something magic about that, I don't know what. Just makes me feel better. Hopefully it enhances your learning too. So the LES, its job is to prevent stomach contents from going back up into your esophagus. But sometimes that sphincter becomes stenotic and it doesn't let food through. And so what happens is you get a buildup of food particles here. And then that can cause dysphagia. So with this happens sometimes, what patients will do is they'll eat several bites and then they'll have to drink a whole bunch of water and hopefully it'll kind of push the whole thing through. And sometimes you may have eaten a really big bite of food and you kind of feel it go down and it feels like it gets stuck right there. Well, in achalasia, that's more happens all the time, not just when you take an especially big bite of food because you're a glutton.
Is there an L in achalasia?
Achalasia. Yeah. So, some of you can't chew gum and walk, and I can't talk and write. Doesn't stop me from doing it, though. All right, so any questions about dysphagia or causes? So in terms of treating dysphagia, you may need surgical intervention depending on the case. We want to raise the head of the bed when eating. We want to slow down feedings. Mouth should be empty before we take the next bite. This should all sound like review from the respiratory lecture, because what's the big risk with dysphagia? Aspiration. And we may need to thicken liquids. And speech pathology is typically the specialty that does the assessment of swallowing. So they'll do a swallowing study and then come up with a recommendation for an appropriate management of that patient. And then you as the nurse are responsible for carrying that out. Any other questions or anything else you need to know about dysphagias?
Could dysphagias cause heartburn?
No, heartburn is something else. We'll talk about that in a minute. All right, so the first subject was dysphagia. The second one is heartburn, or GERD. So GERD stands for gastroesophageal reflux disease. So flux means flow, the flux capacitor. Man, rough crowd. You guys don't know your classic movies. Back to the Future. Yeah, you've never seen Back to the Future? What is it allows time travel? The flux capacitor. All right, so anyway, the word flux means flow, and re means backwards. So it's backwards flow. So in this case, food should flow down the esophagus. But in reflux, it's coming back up from the stomach. Now, the esophagus, the lining of your esophagus, those epithelial cells are designed to resist mechanical friction. So as food scrapes down, they're designed to withstand that. They are not designed to withstand acid. So when stomach contents come back up in here and you've got acid contents in the esophagus, that is going to lead to inflammation of the esophagus. And the symptom for that is called heartburn. Now, you can have reflux without actually having symptoms of heartburn. And that can be dangerous for a reason we'll talk about in a minute. So reflux leads to inflammation, which the major symptom of is heartburn. Patients can also have chest pain that mimics a heart attack as a result of their GERD. Sometimes they'll have a foul taste in the mouth or productive burps, sometimes generically known as GURPS. You can also have what's called water brash, which is where you burp up food contents, but you don't necessarily have a taste. All lovely things. GERD can also lead to chronic cough. You go to sleep at night, you get stomach contents coming up into the esophagus and into the mouth, which can then cause three major complications. It can cause increased tooth decay. It can cause sinusitis, chronic sinusitis, and it can also cause a chronic cough. So if you've got patients with those symptoms, one of the things you need to think about is potential for GERD. Now, in its most severe form, GERD can lead to a metaplasia. Do you guys remember what a metaplasia is? You probably never learned it. So a metaplasia is when a cell differentiates normally than expected. So it's not an abnormal cell necessarily for your body, but it doesn't belong in that spot. One of the classic metaplasias is when a person smokes, the bronchial epithelial cells will change to be more resistant to the smoke damage. And so when you stop smoking, they say as within 6 months of stopping smoking, your bronchi look like normal again. You may have heard something like that. And what they're meaning is that metaplasia goes away, and now you've got normal bronchial cells again. So in the case of this metaplasia, it's a cell that is supposed to be less susceptible to the acid damage. And that is called Barrett's esophagus. The problem is that Barrett's esophagus, metaplasias in general, are a sign that your body is trying to mutate cells. And if it's allowed to continue, it could potentially lead to cancer. So 10% of Barrett's patients end up with esophageal cancer. The problem is that we tend to think of heartburn as just a symptomatic disease. And if your symptoms are under control, you're cool. And if you have it when you're young, no big deal. But if you have it when you're young, by the time you're 40, that's 20 plus years of esophageal damage leading to Barrett's esophagus. So you can actually get esophageal cancer at a relatively young age. Here at PBA, we had an employee. She was 46 years old and died of esophageal cancer a number of years ago.
Is it hereditary? Because my grandma died of that and I have GERD.
Is GERD hereditary? Possibly.
She got the esophageal.
Yeah.
Cancer.
So nowadays with modern treatments, the risk of esophageal cancer is much lower. But if you've got GERD, even at a young age, you shouldn't just ignore it. You need to have an appropriate evaluation and management of your GERD. So, how do we evaluate heartburn? There's a couple ways. One, we can put a probe down the patient's throat, and it stays in there for 24 hours and measures the acidity in the esophagus. Another thing we can do is we can do an endoscopy, where we put a camera down the patient's throat and we look, using the camera, we look at their esophagus and stomach. There are a number of other causes of esophagitis besides GERD, and so sometimes we'll think a person has GERD and it turns out they have something different. So as an example, one of my nephews has what's called eosinophilic esophagitis. He's basically allergic to certain foods. And if he eats those foods, the eosinophils begin to invade his esophagus and cause esophagitis, which causes essentially heartburn and GERD symptoms. So in his case, what he's got to do is basically eats nothing but bread and pasta. It's a hard knock life eating pizza every day.
All those carbs.
Yeah. So, so those are some of the management, some of the assessment things we can do. You can also do what's called a barium swallow. Barium is a radio-opaque substance. And so we basically have them drink this chalky substance. It coats the esophagus, and then you take an x-ray of it, and you can see what are called filling defects. So a filling defect is an indication that there's a lesion in that spot in the GI tract. And those can be done in upper GI with barium swallow, and they can also be done in the lower GI tract with an enema. Now, if our patient has got GERD, whether we've diagnosed it with the 24-hour pH or whether we diagnosed it with esophagitis, endoscopy, then we want to treat that patient with acid-lowering drugs. So at this moment in time, we're going to learn some acid-lowering drugs. These will also be the same drugs that are used to treat ulcers. So the first one is antacids. As the name implies, they buffer acid. So these are usually salts or bases. So first one is magnesium hydroxide, also known as milk of magnesia. You may have heard of it before because we talked about it earlier when we talked about magnesium treatments in Pathopharm 1. What's the problem with milk of magnesia? Or magnesium hydroxide? It's a pretty good antacid. It's quite strong. But what's the problem with it? Adverse effect. Diarrhea. So we usually don't use milk of magnesia by itself. We usually use it in combination with aluminum hydroxide. Now, aluminum hydroxide is a weak antacid, but its adverse effect is constipation. You put the two together and they kind of mellow each other out. I guess there could be some concerns of, it's aluminum, it could cause Alzheimer's disease. But you're really taking it in rather small doses. It's probably not being absorbed that well. So, yeah, whatevs. Don't take it if you're afraid of the Alzheimer's. The next one is calcium carbonate. Calcium carbonate is pretty strong in its antacid effect, but it can result in rebound acid. So the acid levels go down, but then when they come back, they come back up even higher than before. Typically marketed under the name Tums. The magnesium and aluminum hydroxide are usually marketed under the brand names Mylanta and Maalox. And some of you cuss in euphemism by saying, oh, Mylanta.
What are the names? These two?
Yeah. But you can't rely on brand names because there is Tums brand, magnesium hydroxide, aluminum hydroxide. And there is Maalox and Mylanta brand, calcium carbonate. So you actually have to look at what the actual substance is. Now, antacids are not very good at treating heartburn. They will reduce symptoms, but they don't do anything to reduce the underlying risk of disease or reverse Barrett's esophagus. To actually do that, we've got to lower acid levels by inhibiting the secretion of acid. And so for that, we use what are known as H2 blockers. Now, what is the H in H2? Histamine. Histamine is responsible for the secretion of acid. So your chief cells produce it in your stomach, and then those will secrete it in the presence of histamine. So when we talk about antihistamines, what we're talking about is H1 blockers, like Benadryl and Claritin and Allegra. When we talk about these are H2 blockers. So they're selective for H2. So they're not going to have all the drowsiness effects that are associated with Benadryl. The drug names here, they all end in tidine. So there's cimetidine, famotidine, ranitidine, and nizatidine. The two that you guys need to know are famotidine and ranitidine. Famotidine is Pepcid, and ranitidine is Zantac. Now, there is one thing you need to know about the first drug that I mentioned, cimetidine, which is Tagamet, and that is friends don't let friends take it. The reason why is that it's broken down in the liver and can interfere with the metabolism of a lot of other drugs. It also has some other nasty adverse effects that are endocrine in nature. So specifically, if you're a man, it can cause gynecomastia and testicular atrophy. So, friends don't let friends take Tagamet. These drugs are somewhat effective at lowering acid levels, and they can help to reduce the risk of Barrett's esophagus or reverse it. But they're not the best. The best drugs, in this case, would be PPIs, proton pump inhibitors. Now, what is a proton by itself also known as? How would it be represented chemically?
Hydrogen?
A hydrogen what? Ion, H+. So a proton pump inhibitor is an H+ inhibitor. What do we need to do to make acid? How do we measure how acidic something is? The pH, which is a measurement of what? Hydrogen ion concentration. So in order to make acid, we have to concentrate hydrogen ions. What would do that? A proton pump. So when we inhibit the proton pump, we are inhibiting the production of acid. So H2 blockers work by inhibiting secretion of acid that's already been made. PPIs work by inhibiting production of acid. So the drugs there all end in azole. So there's omeprazole, pantoprazole, lansoprazole, esomeprazole, rabeprazole, a whole bunch of prazoles. So the drugs you need to know is omeprazole and pantoprazole. The reason you need to know omeprazole is it's Prilosec and it's available over the counter. Pantoprazole is often used in hospitals because it can be given IV. So, usually if a patient's got Barrett's esophagus, you're going to give them a PPI, and you may give them a PPI plus an H2 blocker. Does that make sense? If the patient has Barrett's esophagus, they're going to get a PPI for sure. And they may also get an H2 blocker. So you can give them both together.
If they don't, would you just give antacid?
Yes.
And you're giving them the H2 to like help lower the histamine levels. That's why you would give it additional.
It's not lowering histamine levels. It's blocking histamine receptors in the stomach. So, if a person does not have Barrett's esophagus and they don't have chronic GERD, they just have episodic occasional heartburn, there's nothing wrong with using antacids to manage symptoms. If the patient has significant disease, by which we mean changes to the esophagus, then you cannot rely on antacids. You have to use H2 blockers and PPIs. And which of them is better? PPIs. If the patient's progressed to the point where they have Barrett's esophagus, they need to be on a PPI. Now, as far as adverse effects go, PPIs are relatively mild acutely, but long-term use of them can result in increased risk of pneumonia. Also, they are associated with a number of adverse effects, specifically in the elderly, and are one of the drugs on what's called the Beers criteria list, which is a list of drugs that elderly folks really shouldn't be getting unless absolutely medically necessary. So some of the adverse effects that can happen in elderly folks include increased risk of osteoporotic fractures. PPIs. Yeah. So increased risk of fractures, increased risk of C. diff, community-acquired pneumonia, which we've already mentioned, vitamin B12 deficiency. So if you remember back to Pathopharm 1, in order to absorb B12, you had to have intrinsic factor being released, and PPIs inhibit the secretion of intrinsic factor. Can also cause kidney disease and increased risk of dementia. So, elderly patients should generally not be on a PPI long term.
Are all those side effects on the Beers criteria, or is that just the...
Those are the reasons why the drug is on the Beers criteria, the Beers list. So, in the hospital, a lot of times, we'll put patients on a PPI or an H2 blocker to reduce the risk of what are called ischemic ulcers. But then, sometimes when the patient gets discharged, they keep them on the drug for whatever reason. And so sometimes, then they go into the hospital the next time, and well, they were already on the drug. I don't know who prescribed it. I don't know. They just keep them on it forever. And so that's not a good practice, because PPI use in elderly is associated with all those nasty adverse effects. So in younger patients, for the most part, PPIs are well tolerated, but in elderly folks, we don't want them to be on them unless it's absolutely necessary. Any questions about the drugs we use for GERD?
No risk effects for H2?
H2 blockers do have adverse effects, but they're relatively mild, and we're not going to go over any.
For the drugs for ulcers, is it just all of these, or is it just PPIs specifically?
We'll talk about ulcers when we get to ulcers.
Okay.
So I'm just mentioning it now since we're talking about the drug. Yeah. 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 So the only reason I mention ulcers is because patients are often put on them acutely for a risk, but then they're left on it indefinitely by mistake. And so we don't want that to happen. All right. Now, these are the drugs that we use for GERD, but there's also a number of lifestyle changes that we need to think about as well. The first one is losing weight. An obese person has more weight on their stomach, so it's kind of like the weight, it can help push the stomach contents up. So losing weight can help. Another thing that needs to be considered is don't eat too much at any one meal. Let the stomach empty completely between meals. That means no snacking. You want to have at least 4 to 5 hours between meals. Next thing is avoid trigger foods. If there are certain foods that you know cause your GERD to flare up, don't eat them. But I love pizza. Yeah. And then in general, there are certain foods that are more associated with GERD than others, such as spicy foods, tomato-based foods, and you can just Google it, you'll get an entire giant list. So consider avoiding those foods as well. And then the last thing is don't eat before you go to bed. You want to have an empty stomach when you go to sleep. Because what happens when you go to sleep? You lie down. And so now it's much, much easier for stomach contents to come up your esophagus than when you're standing upright and you're all good. You can also raise the head of the bed slightly. That can be either putting the bed on blocks, or there's like a wedge that they sell you put underneath the mattress, and it brings the mattress up a little bit. And that will help to maintain postural drainage downwards. The ultimate cure for heartburn, for GERD, is a surgical technique known as a Nissen procedure. Not a Nissan, a Nissen. Now, Nissens are notorious for not really working that well. But I once had a boss who had just really severe heartburn. And so he went to the top GI surgeon at Shands at the time, and he had a Nissen performed, and he did it what's called open. Most Nissens nowadays are done laparoscopically. So in an open procedure, they actually cut the abdomen open. The guy opens things up and mucks around physically in there, as opposed to doing it laparoscopically. And what this guy said, again, he was the top surgeon at Shan's 4 GI surgeries, he said, the way that you make it work is I have to put my finger inside your esophagus, and they basically take some of the material and they wrap it around the edge. And it's like, I've got to wrap it to just the perfect tightness around my finger. And if I do that, it'll cure your GERD. And he had the surgery, and guess what happened? He was cured. He could eat any spicy food he wanted, no problem. Whereas before, he couldn't even look at spicy food without getting GERD. So, that's one person's experience with one surgeon who says that's the key to making it work, and that's why all of these laparoscopics don't work that well.
Why does wrapping it help the GERD?
So what they're doing is, it's also called fundoplication. So you're taking some of the fundus of the stomach and you're wrapping it around the esophagus. You're basically tightening the esophagus down. So Nissens are notorious for not working, but in one surgeon's words, that's because they're doing them wrong. Who's right? I don't know. But if I were going to do it, I'd probably try and find someone who does it the old-fashioned way. I don't know if there are any people around. That was more than 20 years ago now. So, all right. Any questions about GERD, lifestyle, and surgery? Okay. Next, we're going to talk about stomach problems. And there's two basic stomach problems. They are gastritis and ulcers.
What about pyloric obstruction?
Okay, sorry. Pyloric obstruction is, as a cause of GERD, you mean? Or just in general?
Pyloric obstruction, it's got its own 2 cards.
Yeah, we'll talk about that after we talk about gastritis. Okay, we'll talk about it now since you asked. Okay, so what is a pylorus? It's a part of your stomach. Which part is it? The pylorus is the very bottom of the stomach, where the stomach exits into the small intestine. Yes. Yes. So in a pyloric obstruction, a person is going to eat a meal, and then that meal will not go down into the intestines appropriately. That can lead to GERD. It can lead to projectile vomiting, especially in young infants.
So it's a problem with the stomach, though.
Right. It's a problem with the stomach not emptying correctly. So in infants, they usually surgically correct it. In adults, it's usually treated by eating smaller meals, and may require surgical intervention in adults. You can also have delayed gastric emptying from a number of neurological problems, including diabetic neuropathy. And you can also treat that with prokinetics. It just depends on the nature of the obstruction. All right, now let's talk about gastritis. So gastritis comes in 2 forms, acute and chronic. And it's usually associated with stomach pain. So things that can cause acute gastritis, what would they be? Now, when I say this, I don't necessarily mean you have to look up at the ceiling and think real hard. You could just look at the notes and see what the notes say.
Drugs.
All right, so the big ones are H. pylori and NSAIDs. What is H. pylori? It's a bacteria, Helicobacter pylori. It's a bacteria that is able to live in the stomach in the high acid environment. and they can cause ulcers, but they can also just cause gastritis. So how do we know a person has H. pylori? There's a number of ways you can do it. One is a breath test. Another one is an endoscopy, where they put the scope down and they can actually take tissue samples and they can examine the tissue samples for H. pylori. You can also do a blood test, but the blood test looks for antibodies. So it doesn't mean that a person has a current H. pylori infection just because they're positive in the blood test. And then the last way to do it is a stool test. So you take a fecal sample and culture it. If a person has positive for H. pylori, what should we do? Give them antibiotics to treat them for H. pylori. And we'll talk a little bit more about that protocol when we get to ulcers. If the reason the person has gastritis is NSAIDs, what do we need to do?
Take them off.
Take them off the NSAIDs. All right, what about chronic? What about chronic gastritis?
It's a thinning of the stomach lining.
A thinning of the stomach lining, typically, and that could be as a result of, again, H. pylori, but it could also be from overuse of hot drinks. People who drink too much coffee or too much hot tea. What else?
Oh no. They're really bad.
Talking too fast. You can't talk too fast, Dr. Heyman.
How do you treat the acute gastritis?
Take them off the NSAID or treat the H. pylori.
Yeah.
Antibiotics. We'll talk about more about that in a few minutes.
Immune.
So now, for the chronic, so sometimes it's just age-related, which is one of the reasons why PPIs are not appropriate for, in general, not appropriate for elderly patients. Another potential cause is the hot drinks. H. pylori can cause chronic as well as acute. And sometimes there's an immune reaction where patients get thinning of the gastric mucosa as a result of autoimmune disorders. So basically, you're going to treat the underlying condition.
What is
What is what?
vague?
Vague? Symptoms are often vague.
Oh.
Yeah.
So how much hot drinks are we talking about?
I have no idea. I have no idea, and I can't relate because my lips are the limiting factor on hot drinks.
Because I'm like, I drink coffee like 2 or 3 cups a
Yeah.
day. So I'm just like,
Yeah, if it's, I guess it's one of those things where if it's warm, you're okay, but if you like really hot coffee,
yeah,
I don't know.
okay. Oh, true.
We just stick to the cold.
Yeah, it's good.
Yes,
Okay.
stick to your iced coffee.
Iced coffee?
Or just say no to coffee.
No.
No.
Never.
We don't need that kind of negative.
Coffee is life! You must never say that again! Your big gulp coffee.
Yeah.
64 ounces of coffee right here.
He's doing it right.
Soon we'll start an IV and straight into the vein. Okay,
He's doing it right.
so now we're going to talk about ulcers. Now, with ulcers, we typically are going to call it peptic ulcer disease. And the abbreviation for that is PUD. PUD comes in 2 major forms, gastric and duodenal. Typically, duodenal are a little bit less severe in terms of symptoms. They're also more likely to spontaneously resolve. Gastric ulcers are typically going to be more severe in symptoms and less likely to spontaneously resolve. Sometimes they make a big deal out of what's the pattern of pain. Does it hurt when you eat or does it hurt after you eat? But in reality, both of them can occur with both symptom patterns. So it's not that big a deal. And you're not going to have a question on that on your test.
On
the severity of.
The pattern of pain.
Oh.
Does it hurt? Does it hurt when you eat, or does eating soothe it?
That would double
Yeah, that's not going to be on your test. But you should be aware that there is a difference in pattern. So what I expect you to do is know there's a difference in pattern. So when you've got a patient with an ulcer, you can ask them, does it hurt worse when you eat or does it hurt worse after you eat? And then you can look up what the difference is. Does that make sense? The other thing to be careful about is that when we talk about pancreatitis later on, pancreatitis is also associated with pain after eating. So you might think they've got an ulcer when in fact they've got acute pancreatitis. So you just have to keep all of that. If a person complains of pain, stomach pain when they eat, it could be a gastritis, it could be an ulcer, or it could be pancreatitis. So don't worry too much about what the pattern is. Just know that it could be any of those things and they have to be worked up appropriately. And that's not our job as nurses to do that. When you become a nurse practitioner, then you can do that. Does that make sense? All right. So there is a difference, though, between the two. Now, there's another difference between what we call true ulcers and superficial. What is the difference between them? Superficial are, well, they're superficial. They're kind of materialistic, and they don't really care about values. All they care about is the car you drive.
Ew.
So what we mean by superficial is that it only affects the mucosa, not the layer underneath the mucosa, which is known as the muscularis. So a true ulcer is going to penetrate the muscularis and therefore will do what? Bleed. So true ulcers bleed, superficial ulcers do not. Which one is more dangerous?
The bleeding.
The bleeding ulcers. Now, here's another issue with ulcers. You can have an ulcer that bleeds and yet not have pain. On the other hand, you could have a superficial ulcer that is not that severe and have excruciating pain. So, pain does not equal damage. And the worst kind of ulcer would be a painless bleeding ulcer. Why is that? Because you don't know you have it and you could die suddenly from hemorrhage. As far as other symptoms go, a person can have blood. Where would the blood show up?
In the stool.
In the stool. What would that look like?
Dark.
Dark tarry stool? What's that called?
That's last
Melena or melena. Where I come from, we pronounce it melena.
Melena.
Which is the right way? I don't know.
Is that going to be for the true ulcers?
It doesn't matter. Well, yes, true ulcers only, because only the true ones bleed. So, if a patient is having true ulcers, can show up in the stool as melena. Might not show up visibly, so what do you have to do in that case?
Microscopic.
Hemoccult, also known as a fecal occult blood test. What does the word occult mean? Voodoo and witchcraft. Yeah. What does the word occult mean? It means hidden. So in that case, the blood is not visible, but it's there. Now, what about the other direction?
What if it's bleeding? Oh, vomiting.
Vomiting. Hematemesis. So,
Okay.
hematemesis could be a symptom. And if the patient has digested the blood and then vomited it up, what do we call that? Coffee ground emesis. So all of those are potential signs and symptoms of ulcer. Now, as far as the causes of ulcer, there are three main causes. First one is H. pylori. And we've already discussed how we know a patient has it. What are the ways?
Endoscopy, stool test, and breath test.
So endoscopy, stool test, endoscopy, stool test, breath test. You can do blood, but that doesn't tell you if it's a current infection. Then we have NSAIDs. What's the mechanism of ulceration there? Not thinning of the gastric lining, no. How do NSAIDs work? Well, you see, there's this stuff called arachidonic acid, and when you give it in the presence of an enzyme that we're going to call COX, that causes two potential pathways of prostaglandin production. On the COX-2 side, we get inflammation, pain, and elevated temperature. On the COX-1 side, we get a number of physiologic functions, including macrophage function, platelet function, renal perfusion, uterine contractions, and cervical ripening during labor. And we also get secretion of mucus in the gastric mucosa. So by inhibiting COX-1, you inhibit the prostaglandins that are associated with mucus lining of the stomach. But isn't that the same thing as saying thinning of the gastric mucosa? No. Thinning of the gastric mucosa means that the cell lining is thinner. What we mean here is that there's less mucus. So,
She doesn't like it.
how do NSAIDs cause ulcers?
Decrease of the gastric secretion.
Decreasing gastric mucus secretion. Okay. The next one is stress. You see, Dr. Heyman, I told you you're causing me an ulcer. Well, that's not what we mean by stress. What do we mean by stress? Traumatic stress? Oh, I've been traumatized by your test.
Yeah, that's true.
Is that what we mean by traumatic stress?
Like a life-changing event? Like, I don't know.
Yeah. Okay, so what is the mechanism of stress response?
Inflammation.
Sympathetic.
Sympathetic response. Okay, so what was the first sympathetic receptor that we learned about? What are the four sympathetic receptors?
Alpha 1, alpha 2.
Alpha 1, alpha 2, beta 1, beta 2.
Beta 2.
All right, first one.
Alpha 1.
Alpha 1, what does it do? Dilation of the eyes, stomach.
Increase.
Okay, so visceral vasoconstriction and skin vasoconstriction.
Pale.
Now, what does mucus lining rely on in order to be secreted? In order to make mucus and secrete it, what do we need? To the gut. Blood flow. And if we cause so much vasoconstriction that we reduce blood flow to the gut, that could result in a mismatch between acid and mucus, leading to ulcers. Those are called stress ulcers, also known as ischemic ulcers.
So they're different than duodenal and gastric?
Yes, these are causes of ulcers. Duodenal and gastric is location of ulcer. So location, cause. So what is the cause of stress ulcers?
Decreased blood flow.
Decreased blood flow, aka ischemia. So when we talk about stress, what we mean is like you got shot with a gun and the blood loss caused vasoconstriction or maybe shock, and that is what led to the ulcer. Does that make sense? Okay, and there is one last honorable mention, and that is alcohol. We had a little talk today in Pathopharm 1 about alcohol.
How'd it go?
It went fine. So here's the thing. How many of you are afraid of diet drinks because you're afraid of getting cancer? We talked about that here recently?
Yeah, last week.
Last week?
Last class.
Man, I'm old. That's what happened to old people. They keep saying the same thing over and over again. They don't remember because they don't remember who they told. Oh, man.
We all look the same to him. We're just.
Yeah, all you students look the same.
What was their response?
I don't know.
Might have been our response.
It's probably, you're probably remembering us.
Yeah. So, the bottom line is, I don't care if you don't use aspartame or sucralose, but if you're drinking alcohol, you'd actually be better off not drinking the alcohol and eating the aspartame instead.
Yeah, you totally spoke with us about just.
Yeah.
I think it was last class.
Packets right in your mouth.
Yeah. And if you're obese, then the risks of being obese far outweigh the potential cancer that you could get from getting aspartame or Splenda. It's beautiful. All right, back to our story. I'm going to cut that out of this video. Cut! I thought that was a sign for vasectomy. Snip, snip. Cut! All right. So, as an honorable mention, alcohol. And this is typically not just alcohol consumption, like, moderate. This is more like chronic alcoholic type consumption. So we've got our four major causes here, and as far as treatment of ulcers go, we want to treat the underlying cause. So if they're on an NSAID, what we're going to do? Take them off it. If they've got H. pylori, what are we going to do? We're going to give them antibiotics. So the antibiotics, you don't need to know the antibiotic regimen for the test, but I'm going to tell you that there's a couple different ones. So one of them is you can give amoxicillin, and another one is that you give a macrolide. And you always give them in combination with a PPI and also sometimes Pepto-Bismol. So you're going to give an antibiotic. Usually it's going to be amoxicillin or a macrolide in combination with a PPI and sometimes Pepto-Bismol. What's called bismuth subsalicylate, which we'll talk about later. Only you can give you anxiety.
Yeah, so that's for H. pylori, right?
Yes.
I give myself one.
So if a person's got H. pylori, we're going to treat them with an antibiotic, a PPI, and possibly Pepto-Bismol. If the person's got NSAIDs, take them off it. And now, for the stress ulcers, the main thing here is we're going to try and reduce the risk of them occurring in the first place. So, very, very commonly, what you're going to see is almost everyone in the hospital is going to be on either a PPI or an H2 blocker. And then you look at their history, they have no history of ulcers, they have no history of GERD. Why are they on it?
To prevent it.
It's to reduce the risk of ischemic ulcers. Now, why do we prefer the term reduce the risk of rather than prevent?
Because it can still happen.
Because when I say prevent ischemic ulcers, sometimes in your head that means, because they're on it, they can't possibly have an ischemic ulcer. It prevented it. But really the goal is to prevent it. There's still a chance it could happen. So a better way of phrasing it is reduce the risk of. So I'm fairly certain I've said this a couple times in Pathopharm 1, but you can never hear it too many times. So, why are they on that H2 blocker or PPI?
To reduce the risk of ischemic.
To reduce the risk of ischemic ulcers. So, when you guys are in med-surg and you are supposed to look up all the drugs your patient is on, and there's no history of GERD or ulcer, why are they on it? You better not say, this is for treating GERD. Why are they on it?
To reduce the risk of ischemic.
Reduce the risk of ischemic ulcers. All right. Any questions about ulcers then?
With alcohol, what do you do, like an acid and just remove them from?
Well, yeah, you would like to detox them off their alcohol. Good luck.
But would we give them?
Don't send them to AA.
Yeah.
Why not?
Because it's a learned pattern of behavior.
No, because AA only helps about 5 to 7% of people go through it. Okay. But yes, you'd like them to stop drinking if possible.
And we wouldn't give them like a H2 or PPI.
Oh yeah, you're also going to treat them with in all of these cases, you'll be treating them with PPI and with H2 blockers. But you also treat the underlying cause. All right, any other questions about ulcers?
Bismuth is an antibiotic.
Bismuth subsalicylate, pink bismuth or Pepto-Bismol, is a weird drug. It has some antibacterial properties. It can also kind of coat the stomach and reduce acid symptoms, and it can also help reduce diarrhea. So it's a very interesting drug. We'll talk more about it when we get to lower GI. But for now, we're going to talk about nausea, everyone's favorite. Now, there are nausea receptors all over the place in your body. Some are in your lungs, some are in your stomach, some are in your brain, some are in your ear. What? In my ear? All right, let me ask you this question. How many of you get seasick? What's that caused by? Your ear.
The equilibrium.
So the equilibrium. So we also have receptors for vomiting that are associated with sensation. How many of you, if you see someone else vomit, feel nauseated yourself? How many of you, if you smell vomit, want to vomit? And how many of you, if you hear someone vomit? Yeah, and a lot of nurses have like a trigger that is like, that makes me want to vomit. There's like a little gnat around here. I must kill it. Cut. So, a lot of nurses have a trigger that will kind of trigger them to feel nauseated. So for a lot of nurses, it's the smell of C. diff. For a lot of nurses, it's suctioning patients' trachs. Oh, that is so gross. For some people, it's changing ostomy bags. You know, your mileage may vary. But a lot of people, if they see, smell, or hear vomit, that makes them want to vomit. So we have all different kinds of receptors and triggers for possibly vomiting, including contextual triggers. But the big one, when it comes to nausea, is called the chemotrigger zone, CTZ, and it's a portion of your brain. And some drugs can directly stimulate that CTZ. And in particular, the drugs that do that are chemotherapy drugs for cancer. That is why chemotherapy drugs typically are associated with nausea. And when we talk about anti-nausea drugs, the main thing is, how well does it stop chemotherapy nausea? Because that's by far the most difficult to treat. Let's shut that door. Those people are too loud. Yeah. They're going to come in here in a minute anyway, but hey.
No, I don't think it's a tour.
What?
Is it a tour?
It's a tour.
I think now I just shut them out.
Yeah, now they can't get in. Only the cool kids can come here, man. When they come in, everyone stare at them with your mouth open, cross-eyed.
Just the nursing school bus.
Yeah. Don't come in. Don't ever say that. Stay here. Stay as long as you can. Do you know what that's from?
No.
The Hobbit, right?
It's Billy Madison. Come on, people. So I can't wait till I get to go to high school. Don't ever say that. No?
Sorry.
Do you know who Billy Madison is?
Yeah, but I never saw it.
I never saw it. That's okay. You're not missing much. There are some funny quotes, though. Back to our story. So, nausea. So the nausea drugs are rated against how well they help with chemotherapy nausea. And the strongest, the best drugs are serotonin antagonists. And these drugs all end in citron. The best of them is ondansetron, which is also known as Zofran. Zofran is category B, pregnancy, which means that it might be safe in pregnancy, but we don't have any human trials to know for sure. It also works well with, for chemotherapy. It's the best one that we have for chemotherapy. Now, one of the major things about these drugs, or any anti-nausea drug, is that it's going to work best if given before the patient starts vomiting. So when would you give the patient this drug if they're getting chemotherapy? Before the chemotherapy starts. If a person is post-surgery and they're like, I don't know, nurse, I feel a little weird, I feel a little nauseated, do you wait till they start to vomit before giving this? No, you give it before. So one of the important things about PRN is made in collaboration with the patient, but you as the nurse know more than they do. So you might want to suggest, hey, let's take some nausea medication now to prevent things from happening. Question there?
Yeah, it says it can cause dizziness.
Yes.
Sometimes like dizziness makes you throw up because you're...
Yes, it's not so much that dizziness makes you vomit as that vestibular sensations make you vomit. So like being seasick or air sick or car sick. But yeah, if you spin around in circles a lot, that can make you feel a bit nauseated. Or as my son would say, I'm going to vomit now. So, also, we typically would prefer IV over PO if the patient is already nauseated, because the risk that they might throw it up and then it doesn't work is higher. If you're giving it before a patient experiences nausea, so you're giving it, say, before you administer chemo, then you could give it PO. You just want to wait long enough for it to be absorbed into the system. So typically you need to wait at least 30 minutes after PO administration. The next drug class is dopamine antagonists. Now, we've already learned about these, haven't we?
Agonist or antagonist?
Antagonists. We've already learned about these, haven't we? Yeah, what do dopamine antagonists do? What kind of drug are they? Would you like me to give you a drug name to help or jog your memory? Haloperidol. It should be antagonists. They are antipsychotics. So these drugs are actually antipsychotics that it turned out weren't very good antipsychotics. But they were pretty decent at helping to stop nausea. So, in fact, all of the typical antipsychotics can also be used for this. We just don't. So, there's two drugs there. One is Promethazine. Brand name is Phenergan. And this one is more commonly going to be seen for surgeries. The other drug, drawing a blank on its generic name at the moment, but the brand name is Compazine. And that is more commonly going to be used for cancer patients.
Do we need to know that one?
It's not on your list, so no. If you go into cancer oncology, you'll see it being used more often. Now, as far as adverse effects, these drugs have all the potential adverse effects of typical antipsychotics. So, the number one is going to be drowsiness. Number two is anticholinergic effects. And then number three is the potential for extrapyramidal side effects, such as tardive dyskinesia and akathisia. These can be given PO, PR, and IV. It can also be given IM. Now, when you give this IM, it hurts. When you give it IV, it hurts. In fact, it can actually cause necrotic phlebitis. There is a black box warning around promethazine. which says, warning, do not administer this IV push. Now, what I can tell you is that back in the day, when I used to work as a staff nurse, we used to push this stuff like it was water. All right, time for your Finnegan. Right on in. As it turns out, we shouldn't have been doing that. And nowadays, you're not allowed to give it IV push. You have to put it into an IV bag, and then you deliver it IV piggyback over 15 minutes.
But it still hurts.
Well, it doesn't hurt as much when done that way because you're not giving a concentrated dose. Now, what happened is the company that made Finnegan said, FDA, we think that this is potentially dangerous, and we want to increase the warning level on the package insert, and we want to tell people not to give it IV push at all. And the FDA said, I don't know that we have enough evidence to do that. Keep your packaging the same. Then a nurse one day pushed the drug into a patient. That patient's arm had to be amputated. She sued the company that made Finnegan, and the company said, hey, we asked the FDA to give us a stronger warning, and the FDA wouldn't let us. And the jury said, doesn't matter, you're still liable, $7 million, please. That is messed up. Exactly.
She got all the money though.
She got the money, but she should have gotten it from the FDA, not from the drug company.
The FDA has so much money.
Yeah.
They're protected.
So anyway, even when you try and do everything right, you can still get screwed. But most importantly, don't give it IV push because it can lead to necrosis of the vein and potentially cause an amputation. All right, next we have some adjuvants. These are drugs that are not necessarily really good antiemetics themselves, but can be given in combination. So the main one there is steroids. Steroids by themselves don't necessarily really cause that much of an antiemetic effect. But when you combine them with these drugs, you get a much better effect. So that drug name is going to be dexamethasone. There's also a prokinetic drug. So what do you think a prokinetic drug does? What do you mean by kinesis? Movement of what? Not the drug. What are we treating? Nausea. Moving what through the body? Food. Sometimes the reason a person has nausea is because there's too much food sitting in their stomach from gastroparesis or delayed gastric emptying. So if we can help speed things along, maybe they won't feel as nauseated. The main drug there is called metoclopramide. Also known as Reglan. Reglan works by blocking serotonin and dopamine. So it has some of both of their action. You can't give it IV push. You need to give it by IV piggyback. And it does have the potential to cause tardive dyskinesia and other extrapyramidal symptoms. And it has a number of other weird issues you can look up at the time you give it. Not going to be on your test.
What's piggyback? IV piggyback?
What is IV piggyback? Since we're in the lab, this is an IV main set. So it's got a bag of fluids. So in this case, what is it?
Sodium chloride.
Sodium chloride,
9%.
0.9%, also known as normal saline. So this little guy is also, there you go, is also just sodium chloride. So what you can do is you inject the medication into this side right here. Sorry, this side right here. And then you put the tubing in this and you hang it like this. So you move this guy down and you hang this up here and then you connect this line to your main port. See? So now, because gravity pulls things from higher rather than lower, it'll pull from this bag before this bag. So when we say IV piggyback, what we mean is a small bag that is run in instead of the main line. So it piggybacks onto the main line. Does that make sense? Okay.
And then when that one empties out, we move on to the main one.
Right, so when this is empty, then it'll start pulling from this bag.
Okay.
So that is what we mean by IV piggyback. So you're gonna drop the either the metoclopramide or the promethazine. You inject it into here, the little diaphragm, and then mix it, and then you're gonna administer it through the other port into the IV. So that's what we mean by piggyback. All right. Next, we have what is known as dronabinol. Now, I was like, where's my...
Matches your lips.
Dronabinol. So, here, I'm just going to erase all this stuff.
That's a separate class, right?
It is. Well, it's not a class. It is a drug. So,
On the adjuvant.
so the next class is going to be cannabinoids.
Is that what dronabinol is? No.
So, what is a cannabinoid? So, activating cannabis receptors. So, what is cannabis?
Wait, for real?
Yeah. So, what is cannabis? Marijuana, hash, hashish, Mary Jane, reefer, toking, weed, pot. I've never heard of these names.
So are these medical marijuana?
Those are not medical marijuanas. Those are just nicknames for pot.
No, is these?
So
cannabis?
some are. Now, what is approved is a drug called dronabinol. It is essentially artificial THC, which is the active substance in marijuana.
So you're getting high?
You're getting high, are you?
No.
You're just having the good effects of the cannabis, the THC, right? That lowers the nausea.
So the purpose of the THC is to lower nausea, but
THC.
it's still THC. So the key here is it's not a very good antiemetic. The major use for it is in cancer patients who have anorexia. How many of you have ever had the flu, like a really bad flu? What did it do to your appetite? You couldn't eat at all. Like nothing tasted good. You had no desire to eat whatsoever. That inflammatory process is also present in some cancer patients. So especially toward the end, a lot of times as patients are being treated for their cancer, they could do okay if they could eat enough food, but they have no appetite. So what THC really is best at, and dronabinol, is increasing appetite, which is a side effect in marijuana world known as the munchies. So dronabinol, the main use of dronabinol is increasing appetite. Now, as far as adverse effects go, think of the adverse effects of marijuana. Okay, so decreased volition, depersonalization, temporal dissociation. That's a good one. I love that one. And what's known as a bad trip, dysphoria. Now, the FDA thinks that feeling good is also a problem, so euphoria will also be considered an adverse effect, even though that is the goal in many people who do use THC. What is volition? What is volition? The will to do something. So what is avolition? No will to do anything. So there's a really funny commercial back in the 80s where, you know, like the anti-pot commercial, where they had these two guys who were in a basement, and one of them's going, oh, everyone says pot will make you do marijuana, all these bad things will happen to you. But, you know, I've been doing marijuana my whole life, and nothing bad has ever happened to me. And just then you hear, like, someone from upstairs go, you know, John, when are you going to go look for a job? Shut up, Mom. And then the narrator goes, pot can make nothing happen to you, too. So that illustrates the idea of avolition, that, you know, I just don't want to do anything. I just want to chill, mellow. Depersonalization is where you feel like your body parts are not your own body parts. So you're like, it's my hand, but it's not my hand. It's someone else's hand. Who's controlling it? So that's depersonalization.
Do you still show up on drug tests?
Yes. If you do a drug test on a person who's on dronabinol, they will show up positive for THC. Temporal dissociation. What does temporal mean? What is temporal? And it's not of your temple. Temporary, so time. So temporal dissociation. What does dissociate mean? To feel disconnected from. You feel disconnected from the passage of time. So I had a friend in high school who was like, dude, Pat, you know how like we're hanging out, you know, we were at a camp, and she's like, you know how we're hanging out right now, we're on these swings. And she's like, and you know, like if we had marijuana right now, we could be on these swings all day long and it wouldn't even matter, because like you wouldn't even know that it'd been all day. So it separates you from the passage of time. You don't know that time is passing. What's that called?
Temporal dissociation.
Temporal dissociation.
How old are you in this game?
I just want to see someone.
I was 15 at the time.
Okay.
Yeah. So I was 6. Yeah. Dysphoria, bad trip. You know, patient can feel all sorts of weird things when they have dysphoria. And then euphoria, well, you know,
Feel good.
I feel good. All right, any questions about dronabinol? Now, we're going to mention medical marijuana at the same time. Medical marijuana is not been well studied because it's been illegal to study it unless you had permission from the FDA, and the FDA was really only approving people who wanted to study it to prove negative effects. The idea behind medical marijuana is basically, well, it's like Marinol, except you're getting a higher dose of it probably, and you're also getting everything else that goes along with the marijuana plant. You're having like potentially 300 substances being ingested or inhaled, not just one substance. Then there's what's called CBD oil. What is CBD oil? So basically what you do is you take the marijuana plant and you turn it into an oil, an essential oil, an essence. So there's 2 different types of CBD oil. There is what's called full spectrum, which does have THC in it, and then there is not full spectrum. Now, the full spectrum variety just takes regular marijuana leaf and creates the oil out of that. And the way that they create the not full spectrum is you do the exact same thing, but you use a hemp leaf that has been genetically selected to have low THC levels. So how many of you have ever eaten hemp seeds? Same plant as marijuana, just doesn't have THC in it. So, when you're getting full spectrum, you are getting a small amount of THC. When you're using CBD oil that is not full spectrum, you're not having the THC, you're having all the other things that are in the marijuana plant. Does that make sense? Now, is CBD oil effective? You know, for a long time, the only way to do research on it was to get permission by the FDA, who was only approving people who wanted to prove negative effects. There haven't been any really good large-scale trials on it, but most of the trials that we do have are either or nope. But you will still find dozens and hundreds, maybe even thousands of people who absolutely swear by it. There are some, not cancers, there are some epilepsy-type seizures that seem to respond very well to CBD oil. There are some people who have neurological disorders who claim that they can't live without their CBD oil. Now, in terms of the larger scale research, none of those claims have been proven. And when we do large trials, for the most part, CBD oil, what does CBD oil treat? Everything. Right? You can treat your aches and your pains and your algias and your neuralgias and your myalgias and your anxiety problems and your sleep problems and your... Is it a magic feather? Is it a placebo? I don't know. But you know what? It's your money. So if you want to do it... Oh, wait a minute. If you do CBD oils, you will show up positive for cannabinoids on a drug test. So if you're a nurse, you might not want to do the CBD oil. Check your hospital's policy and get in writing whether you can do that or not. Does that make sense? Nothing worse than getting fired for doing something that you thought was okay. By the way, at the federal level, CBD oil is still not considered legal.
Wait, what?
At the federal level, CBD oil is still not legal. It might be legal on a state level, but it's not legal at the national or federal level. The same goes for medical marijuana. That's also a state-by-state issue. Here in the state of Florida, medical marijuana is legal, but the farm has to have a special license. And it's really difficult to get that license.
Are all of these drugs that we're talking about still like for nausea?
Yes,
Okay.
for nausea.
Still talking about.
Yeah. So lots of people use medical marijuana for nausea. Some people will use CBD oil for nausea, but neither of them have been studied on a large-scale basis for it. And what little research there is, for the most part, shows not much benefit, if any. If you are choosing to do CBD oil, be very, very careful, because it might end up you lose your job. Any questions about dronabinol, THC, marijuana, and CBD? All right. That was fun. Let's take a break.
I gotta go.
Me too.
I'll wait it out.
Here,
And
Should
then
we-
you never did marijuana because you didn't want to be like pot or pot.
Pat, you're just a pat head.
Professor Heyman, for clinicals for next semester, do you know what the schedule would be like, or somewhat? Can you say?
For clinicals?
Yeah, for like fundies and psych. Like,
Well, it's wildly variable this year.
oh, really?
Yeah, because we have three groups that are going in the afternoons, one on Mondays, one on Wednesdays, and one on Fridays for fundies that are going up to Juno Beach, to the Waterford. But for the most part, you're going to be either Wednesday, Thursday, or Friday.
Yeah, we have Friday for fundies.
Mhm.
And then morning.
Morning ones are usually, for fundies are usually 7, and for psych it's usually 8.
Would we leave at 4 o'clock for psych?
What do you mean?
Because it says 8 to 4.
on like the schedule.
No.
No.
It's usually, well,
What's the longest?
8 to 4?
Yeah.
That's weird.
Yeah.
No, if you start at 8, usually you end at 3.
Oh, okay. And then you start at 7, you leave at 2.
Yeah.
So, for the VA, will that fall under the fundies category?
VA, you'll probably start at 7.
But with that,
Is that fundies? Would that be?
I think you're doing fundies and psych at VA. That's the whole premise, is that you do both of them.
Oh,
so we don't have to go to one location then.
I didn't know that. I thought with like once you choose like the VA, it's only for one.
No, it's for both. That's the whole thing. It's
Oh, I didn't
because
know
that process of getting your fingerprints and everything
Yeah.
is so troublesome
Yeah.
that if you're going to do it, you're going to do both of your clinicals there.
Oh, okay.
Hey. Dogs. Oh, Shelby's not here today. I felt like the room was off balance. We don't have enough redheads.
When's the final?
Thursday, the 8th. Yep. And we need to talk about our last test, because that last test is going to be on Tuesday. And really, that's the only... What? Not this coming Tuesday, but the one after that. So we have to decide what time of day we're going to do that. Because the only thing that... Yeah, the 6th. So the Pathopharm 1 kids are going to do it in the morning. So I was thinking is if they do theirs at 9, and then I do a review for them. So that would put the review, we'd probably be done no later than 11. You guys could actually take your test at 11 if you wanted to.
Why would we want to take it on a night?
Because then we can go to PDQ.
I thought we were going there this Tuesday.
No, we're going to Chipotle.
Oh, we're going to 2 places now?
We could.
Well, you see, it's really hard when you commute an hour away, 45 minutes away. So it's like, it's hard to get up early. I like to get here to study for a few hours. So I kind of.
So we have our test for Tuesday, and then the final that Thursday.
We could go to lunch at 11. We could go to lunch at 11 and then have our test at 12:30.
No, that's not
No,
an option.
that's
I mean,
not
you
even an
guys
option.
can.
That is
You
not an
guys
option.
really can, but I will.
I will sit here.
Or I could just go to lunch with them and not you guys.
What?
How?
Hey, Ashley's the one who didn't want to do lunch.
No, I did not say that. I said I want to have my time to study in the morning and not take this test at like 11. What is that? Is that yoga? So good. I mean, whatever you want to do, I don't care. At this point, I know like nothing sense. So good.
Forager,
That's the way it's supposed to.
cashew yogurt.
Not that I'm complaining.
It's like the healthiest yogurt.
Are you gonna give a snack?
It's not really yogurt.
There's no way I would ever eat this.
Why? It's good. It tastes good. Put some in it.
No thanks.
Why would you eat it?
It's good.
It's 140 calories and only 3 grams of
Hey,
protein.
but it's
Have
good.
you seen the one that?
If I'm gonna be eating yogurt, it's got to be high
But
protein.
it's not really yogurt.
Oh, I can
Cashew
eat
dirt.
shakes, and they're like 11 grams of protein. It's a little breakfast shake.
See, I
It's
need
so good.
protein shakes, so I didn't do that. I already
Yeah.
have enough protein in my
I,
This is cashew.
what I do is the
I do the Yoplait one that has a whole bunch of protein. It's really good.
Nice one.
Like yogurt, so like artificial.
yeah. When it comes to yogurt, I do the Friendly Farms from Aldi. They're non-fat Greek yogurt.
Have you ever tried Siggy? I don't like that. It's gross.
Siggy?
Yeah, I really don't.
I don't know.
It's so good. Yeah.
Oh, I've tried that. It's not.
But the Friendly Farm stuff tastes okay, but the most important thing about it is that it has the most amount of protein and the least amount of calories. But that's what I've been doing for
Oh, I get
protein
those,
lately.
the shakes.
Yeah.
See, I like to like make my own things.
Christine, you said 11 grams of protein. I do these ones.
I said 11. Are they good?
Ashley, you said 11? I do those.
So much to drink. These are just a tiny little thing.
So that's 11 ounces. It's less than a can of
This
Coke.
is like 4. It's tiny.
Everything is based on a can of Coke.
That's the measurement.
How does it compare to a can of Coke?
Let me pull it up. I think it's 11. It's a probiotic.
You know what that is?
You're dipping it in.
It's an Oreo dipped in that protein drink. It doesn't penetrate very well.
Why do you
It
only
doesn't
have
work
half
that
an
well.
Oreo dipped in there?
Because I already ate the other half.
Oh.
There's a protein shake, and there's called, it looks like a juice box almost. I've had before, and it's really good.
Real descriptive there.
I'd rather like get like powder and just make my own.
It's
do you
7
look at?
ounces.
Is that you?
Oh, is that you?
That was when I used to be a lifeguard.
I'm really burnt.
Skin cancer.
What? Say again? Premier protein shakes? I don't know.
I just kind of force myself to.
Yeah, but they have ones that are
I
like
don't like something,
enjoyable.
but I don't like something that's gonna be like.
Yeah. All of my arm hair was bleached blonde. Like I looked like Moses after he saw the Lord.
Your hair is really blonde.
But how many calories? 120 calories. 5 grams of protein.
What you looking at?
I'm like, what are you looking at?
We just all of a sudden looked over.
No, I've been like staring up at the
Oh.
phone for the conversations of protein drinks and
Yeah.
Oreos.
Where's Shelby?
Let's just say. At least that's the story.
Okay, you know how
That's her story.
At least that's the story. That's the lowdown.
Where's Cody?
Drowning his own sorrows. I don't know.
Tell him how
He's a
good the
mess.
Oreo milk is.
What? Did he break up with his girlfriend?
No, he's just a guy.
It's
We're
so
a guy
worth
who
it.
needs like a mother. You know what I mean?
So
They just the other day was like, "Have you ever talked to Cody?" And I was
Just
like, "Yeah."
when
It's like
you're
you haven't done anything uncomplicated yet.
I shoot.
Like not one thing.
He's gonna lose
Not one
points.
thing.
Oh no.
So I texted him and I was like, what day don't you work this week so I can come over and police you if you want to continue nursing school? Like,
Oh, poor guy.
Taylor.
See, you should have stayed in Patho.
he's been working doubles for
Yeah.
6 days a week.
And where does he work?
Happy Trail.
Peaches and cream.
Taylor.
Those just cracked
Extra
eggs.
sugar.
They have like so much protein, but it's like no carbs.
Yeah.
So good.
Sukamana.
Talking about like just like shakes. I want a milkshake.
She heard back in like a day.
From
Crack an egg. You just put an
Okay.
egg in
You
it.
just put an egg in it.
Big old
It's
fat.
like,
It's
so good. Yeah.
It's
And you open
been
it
since
up,
last
it has
semester
like
since I've had one.
Potatoes,
potatoes,
bacon,
cheese,
ham,
like stuff like that.
I'm
There's
like
only like
so
8 grams of
like that
carbs.
smells like that. Like ooh.
The
Sounds so good right now.
I'm just not working out right now, so I can't do that to myself.
Yeah. Yeah, they're really good.
You're not working out right now.
This class has ruined everything. I don't want to work out anymore.
I work out Monday, Wednesday, and Friday.
And
I
you,
used to do
and
that.
you work too, so you
Yeah, and I work.
work.
I mean, I'm not full time like you, obviously, or associate dean of a nursing school, but
And then I do video editing until 2 in. So
I watch.
What's your
videos
excuse?
in the morning.
I'm so weak. I was lifting weights.
I
And
literally
you're listening
watch
to my
your videos.
conversation?
What time do you wake up in
I've
the morning,
never
Professor
worked out.
Heyman?
So like, I
What?
Weekday,
like legs.
What's your
weights,
weekly
and I was
like?
okay, I'm gonna try this
wake
thing.
up
And I tried to do it,
schedule?
I was like, oh my gosh, I can't even do it.
most days I wake up around 7 to 7:15.
I got up at 7:30, and then I look at it, and I'm like, 7:45 to 8.
I usually wake up.
Yeah, lately I've been like 7 o'clock. Can I go back to sleep? Snooze for 5 minutes.
Yeah,
Ruin the next half hour of sleep.
Or do your kids wake you up on the weekend?
Combination.
Okay.
And with my siblings, their kids, they just wake them up constantly, so they haven't slept in like years.
Yeah. That's what it is with my niece and nephew. They wake up their kids at the meetings.
So my kids have nice things.
All right.
Don't do it. We don't have to start again.
Lakin is back. Now we're just waiting on Serena.
Totally just like leaving it during the end of it.
Really? I found it interesting.
I actually like the stomach stuff so far.
That's what you're about cardiovascular.
Yeah, well, next we're going with constipation, so.
Oh, fun stuff.
Or we could do diarrhea.
Milk of magnesium.
Whichever one.
Right?
That stuff is so gross. I had to take that for my colonoscopy and I was it's like gagging on
But
it.
yeah, we use like
So gross.
besides like marijuana for people that have like nausea problems because of the chemotherapy. Can we give them like little Pediasures and stuff like that?
Oh,
Sure, why not?
I'm just wondering because like I know I have like this. My mom's friend has cancer. She just drinks Pediasures because she doesn't know the thing.
Yeah.
And she doesn't like eat because she just drinks it.
Something, yeah. Seems easier.
Yeah, whatever doesn't trigger your nausea, I guess. The smell of Inshore. That stuff is vomitous. That stuff is vomitous.
I tried to drink it in the morning.
Yeah.
Just like,
That Fairlife protein drink tastes pretty good. I mean, it has a slight aftertaste, but
I feel like the smells usually are
what? Not so much a protein aftertaste. I think it's sweetened with sucralose, and it also has monk fruit in it.
Yeah.
So I don't know. It's just slightly not chocolate milk taste. But for the most part, it tastes just like chocolate milk.
It's supposed to just fill up your stomach.
Tasteless rice cakes.
Yeah.
All right, we got to get started again.
Okay.
You know, put some avocado on top and cayenne pepper.
My volition is gone.
Same.
I am now avolitional.
Ditto. Ditto.
All right, we're going to do the rest of this class with me sitting down.
all right.
I don't have the will to stand. I've taken too much marijuana and I can't stand up anymore.
Life
Just raise your seat up. All right.
I look, you want to stand in front of the camera and eat this one.
Do it. I'm just gonna advertise. No promo.
All right. All right, everybody. What are we doing here? All right, so next we're going to talk about lower GI. And for lower GI, we've got two main issues, which is either too much or too little. But before we get to the small intestine, the large intestine, we need to talk about the small intestines ever so quickly. So, the number one most important thing about small intestines is small bowel obstruction is life-threatening. Now, in your notes, there's a slide that has a whole bunch of potential causes of bowel obstruction. Volvulus and intussusception and all kinds of weird words. You need to be familiar with those terms. There will be at least one question on your test that expects you to know what those words mean. And the most important thing is, if they've got an obstruction, potentially life-threatening, they should not be eating anything by mouth, and for the love of God, never give them a laxative.
3 words just came to my mind. Currant jelly, stool. Is that intussusception?
Yeah. We're
It's like I'm asking you back.
all we care about right now is know the words, know that those are small bowel obstructions, and never ever give them a laxative, and the patient should be NPO.
Are you talking about like herniation? No?
Yes. All right, so now that we've talked about that, let's talk about large intestine. So the first thing we're going to do is constipation, everybody's favorite. So what is constipation? And generally speaking, constipation is defined as no bowel movements within 1 to 3 days. Now, depending on who you ask, that might be dramatically too lenient. You need to have a bowel movement every day. The only reason that people don't have bowel movements more often is because they don't eat enough fiber, because they're eating a meat-based diet. And if you were eating a plant-based diet, then you would have bowel movements every single day. You would have 4 bowel movements a day. But the medical standard is going to be typically more than 3 days. But a lot of people, if they don't have a bowel movement every day, are going to start complaining of being constipated. Although technically, according to the standard, they're not yet constipated. If you've ever hung out at an old folks' home, what is the number one thing that those guys talk about? Their bowels. I haven't had a bowel movement today. Like, the day cannot be good day until they've had a bowel movement. So, some of it has to do with expectations, and some of it has to do with the food you eat. And then there's also the difficulty of having a bowel movement. So you might be having a bowel movement every day, but it's difficult to go, or it hurts to go, or it feels like your stool is too hard as it comes out. Those are also kind of symptoms of constipation, but they've actually done studies where they take the mechanical pressure that it takes to smush the poop. And as it turns out, constipated poop is no harder than regular poop. Go figure. But you'll often hear complaints of those things when a person has constipation. So, when it comes to constipation, the big things that we need to think about are water hydration, fiber intake, and exercise. These are the big lifestyle things that will help to improve and ensure that a person has more or less normal bowel functioning. If a person doesn't do these things, then that's our first step. Now, where should they get the vast majority of their fiber? From the diet. And that's going to involve education. So, first of all, what kind of foods do you eat? Second of all, what should you eat? Third of all, how can you shift from what you're currently eating to what you should be eating? Does that make sense? Mm-hmm. Okay. By the way, if you eat too much fiber, that can actually cause constipation. So, it's a little bit of a Goldilocks story. Too little, constipation. Too much, diarrhea. Too much, constipation again. All right. Now, in addition to those lifestyle things, there's also a training component. All right, how many of you had this happen? I've got to go. I got to go right now. But there's no toilet available. And so what do? You hold it. And what happens to the urge? It goes away. When does it come back? For some people, the answer is an hour later. For some people, the answer is 8 hours later. For some people, the answer is tomorrow. And for some people, the answer is never. So, the longer it takes for that urge to come back, the more likely a person is to become constipated. And this is particularly the case with a lot of young girls as they become women. Bathrooms that are not my bathroom are icky. And I can only go in my bathroom. And so there's a training component to that constipation in that your expectations lead to the constipation. So, the moral of the story is, when you gotta go, you gotta go. The next component is laxative abuse or overuse. Now, some people have naturally fast bowels. They can take a laxative, they can do a bowel prep for colonoscopy, and then as soon as they start eating again, within about 6 to 8 hours, they've got a bowel movement. Other people, if they've had a bowel prep where their bowels are completely cleared out, it might be 3 days before they have another bowel movement. So, in those elderly population in particular, where they're using laxatives to have a bowel movement every day, it might be that they're not actually constipated, their bowels are empty. There's nothing to bowel. So what they need to do is lay off the laxative and reestablish a normal pattern of defecating. So that has to do with expectations, or you might say unreasonable expectations of bowel movements. Now, in addition to these things, there are also drugs that can cause constipation as an adverse effect. What's the number one? Oh, don't all answer at once.
Sorry, we're still writing.
There are a number of drugs that are associated with constipation. The number one is
Opioids.
opioids, right. Next we have the very first drug class you guys ever learned. What was it? Anticholinergics. The other issue that can also affect people is their nerves. Some people, when they get nervous, start having diarrhea. Others, when they get nervous, stop pooping altogether. So all of these factors and lifestyle factors also play a role, and then medications. Another thing to consider is if a person has had surgery and they've had general anesthesia, that can also lead to constipation, because it basically put their bowels to sleep. The thing you have to watch out for there is the potential for what's known as a paralytic ileus. Or basically the ileum never kind of wakes up and starts functioning again. And that's potentially life-threatening. It's a small bowel obstruction. All right. Now, when it comes to treating constipation, after we do the lifestyle things, there are a number of drugs that we can use. So the first drug is fiber. Now, fibers are not, they are considered drugs in the sense that we can prescribe them, but they're also available over the counter. So patients can use or abuse them at will. So there's various number of different types of fiber, some of which are less palatable, some are more palatable, some are, some have a lot of gas associated with them and some don't. So your individual mileage may vary. So psyllium husk is the kind of the oldest one that's Metamucil, and it doesn't dissolve fully in water, and it's gritty when you drink it. Nowadays, we have fiber gummies, so you can just eat a gummy bear. No matter how you eat the fiber, you need to have adequate hydration as well. Fiber is typically considered a slow-acting laxative, so it's not going to necessarily cause bowel movement until 2 to 3 days later. However, some people are what you might call hyper-responders. Some people, if they just eat too many oatmeal cookies, the fiber in the oatmeal will cause a laxative response that day. Is that a personal experience?
I just like oatmeal cookies, but they don't really help me.
All right, whatever. So that's fiber. Then we have what are known as stimulant laxatives. So the main one here is bisacodyl. You can get it over the counter, and it's available in two forms. One is in a pill form, take it PO, and the other, it's bisacodyl.
Oh, sorry. I couldn't see it.
Yeah. And the other form is a suppository. Now, they act like different drugs when they're given the different ways. When you take it by mouth, it takes about 8 to 12 hours to work. So usually you take it at night for a morning surprise. And when you take it as a suppository, it typically is much stronger in its action and causes bowel movement within about 2 hours. Stimulant laxatives are the laxative of choice for patients who have opioid constipation. So there used to be a number of other ones that we covered, but that's the only one we're going to talk about here.
You said it's used for opioid constipation?
Yeah, can be.
Can be.
All right. Next, we have what are known as osmotic laxatives. And these are basically substances that can't get absorbed very well in the gut, so they draw water into the gut. Oh, you know what? I'm skipping one. Sorry. Skipped. Lies. So we have stimulant, then we have surfactant. So if you put water drops on the table, what will happen to the water drops? It's not just like this very thin sheet of water. They like kind of beat up into water droplets, right? Yeah. Why is that? The tension in here is so tight, you can cut it with a knife. I just told you the surface tension. Right, surface tension. So what does a surfactant do? Break surface tension. It breaks surface tension, which allows the water to form smaller droplets than it otherwise would. And that basically allows water to penetrate into the fecal mass deeper than it otherwise would, thereby hydrating it, causing it to be softer. So these are sometimes known as stool softeners. And the most
matter if you were really constipated, it's hard to not.
Yeah. These are called, the most common one here is docosate sodium. The brand name is Colace. But the really important thing to know about docosate is that it comes in other salts as well as sodium. So there's also docosate calcium and there's some other ones. So don't just assume that you know that the docosate you're giving is Colace. It might be a different type. Does that make sense? Mm-hmm. Okay, because that's an easy way to have a medication error. You assume it's always docosate sodium because 95% of the time it is, but then this one time it wasn't and now you messed up. Don't do that. They don't really work that well. They kind of make the feces into this kind of soupy mess, but it doesn't always make it that much easier to go. They used to be the drugs that everyone prescribed for opioid constipation, but not that effective. Next, we have osmotic laxatives. So in an osmotic laxative, you've got a substance that can't be absorbed very well in the gut that is going to pull fluid from your intestines into the gut and then it gets pooped out. So the vast majority of the laxatives we're going to talk about are part of this class. So one we've already mentioned in the past, magnesium hydroxide, magnesium citrate, actually all of the magnesiums. There's also something called polyethylene glycol. Glycol. So, polyethylene glycol is, the brand name is Miralax, but there are other brand names out there now because it's been around for a long time. When given by itself, it is a relatively slow-acting, mild laxative. And takes somewhere between 1 to 3 days to work. It's colorless and odorless and dissolves instantly in liquid. Kind of like iocane powder. Now, in addition to giving it by itself, you can also sometimes give it with electrolytes. And then this becomes an evil known as Go Lightly. And it makes like a gallon of liquid. and you use it for a bowel prep for surgery or for colonoscopies. So the most important thing when you're doing a colonoscopy is that the bowels have to be completely cleared of any fecal matter. If you do a colonoscopy when there's fecal matter in the bowel, you might as well not have done the colonoscopy. You just wasted $2,000. Congratulations. So one of the ways that they will do a bowel prep is by prescribing Go Lightly, which is the polyethylene glycol plus the electrolytes. So it's like a gallon of this liquid, foul-tasting, disgusting liquid that you're supposed to drink. Oh, you can flavor it, but it's still disgusting. The reason that doctors like to prescribe it is that it has very low risk of electrolyte imbalances because of the electrolytes. But they've obviously never taken it themselves, or they wouldn't be prescribing it as often. Because not only does it make you have to go that way, it also makes you have to go this way. And what you're typically supposed to do is you take a cup of it and you drink 1 cup every 10 minutes or every 15 minutes until it's gone. What they don't tell you a lot of times is you don't have to drink the whole thing. You're supposed to drink that up until you've drunk half of it. Then you evaluate the stool. Is it clear? If it's clear, you can stop. But a lot of times they don't tell people this, so people drink the entire thing. Now, once upon a time, I had to have a colonoscopy, and I had Go Lightly. So I'm like, you know what? I'm a man. I'm not going to do this 1 cup every 10 minutes nonsense. I'm going to drink 1 cup every 5 minutes. What's interesting is that you can actually see your stomach moving from the outside. Yeah. And I thankfully did not have to vomit, but I know many people who do have to vomit when they take Go Lightly. So not only then are they taking Go Lightly, but they're also then now taking Phenergan at the same time. Nasty stuff. So take half of it, see if your stool is clear, and then if it's clear, stop. If it's not, then drink the other half. Now, one thing to think about anytime a person is doing an osmotic diuretic, especially for bowel prep, is that the liquid that comes out the other end is slightly caustic. What does that mean? It burns your bum. So, what you should tell a patient is, when you go to the pharmacy, get yourself some Vaseline or some butt paste, or yes, Boudreaux's butt paste, or some calmoseptine, or some zinc oxide thing to protect your bum. So, you apply it before you start, and then after every bowel movement, do it again. They call it a bowel movement, but it's more like a bowel squirt, because, hey, you guys chose to be nurses. There's no solid fecal matter. It's not a bowel movement. Yeah, anyway. So, stuff is caustic, and use that to help. Your patients will thank you. Well, they might not, but if you don't tell them that, they'll be mad at you. Especially if they find out later that you could have told them that. So, anytime a patient's got a bowel prep, some sort of skin protectant for the rectum. Next, we also have Fleet phosphosodas. These are all under osmotic. The nice thing about the phosphorus-based ones is that instead of taking like this giant amount, you're taking a very small vial. You're basically taking a shot, and then you have to drink a whole bunch of water. The potential danger with these ones is that they can lead to renal failure.
Soda?
Fleet phosphosoda.
Is that an E or an O?
Yeah, man.
That's an E. Yeah, there.
Soda.
Soda.
Fleet phosphosoda.
There's no H, that's
Phospa.
Oh,
Phosphosoda. All right, so let's get started. So I forgot to talk about 2 drugs for ulcers that are not acid lowering. So I need to talk about those.
I know the 2 drugs, but do we need to know motion sickness drugs? Because it wasn't on our drug list, but it's in your paragraph.
All right, so I'll mention motion sickness drugs too.
Okay.
So I need to go over a couple drugs that I didn't include on the last lecture, so let's talk about those ever so quickly. When it comes to ulcer drugs, there are 2 ulcer drugs that are not acid lowering. And the first one is called misoprostol. And this is basically an artificial prostaglandin. So it acts locally in the stomach to increase the amount of mucus production in the stomach. Second one is sucralfate. Sucralfate is a gel that it forms a protective gel and it sticks to the ulcer, and that kind of prevents the damage from the acid occurring. The downside of sucralfate is that it can interfere with the absorption of certain vitamins and drugs.
So fast. I can't keep up with you. You're stressing me out.
Everything I'm saying is in your notes, so you don't have to write it every word down.
No.
No, I must produce a transcript of what you say.
No, because then you say something and then I forget like the main point of going before it.
So, anyway, that's pretty much it for those 2 drugs. By the way, misoprostol is also used during labor and delivery to ripen the cervix.
Goodness.
And what do I mean by ripen?
Help efface it.
Help dilation and effacement. All right. The next thing that I didn't talk about was antiemetic drugs. Motion sickness drugs as an addendum to antiemetic drugs. So motion sickness drugs are drugs that are specifically used to reduce motion sickness, and the vast majority of them are antihistamines, and it's basically the drowsiness that is causing the anti-nausea effect. So basically, by suppressing your brain function a little bit, you have less vomiting. So pretty much all of them, Dramamine, Meclizine, whatever, Bonine, they're all antihistamines.
I think it was like cyclizine, meclizine, and diamine.
Yep.
Those are the ones in your paragraph.
What else? None of them are on your test.
Oh.
You asked for it.
No, I was wondering if we had to know it. Because
Well,
it was on the PowerPoint.
They're helpful. I mean, we do live in Florida, and lots of people
If they're not going to
like to go on ships around
So
here.
we don't need no motion sickness drugs.
Well, you don't for your test.
Okay.
Okay, well then we don't need to know it.
No.
Don't share that thing with me.
So let me ask you this question. Is there such a thing as an effective non-drowsy motion sickness drug?
No.
Not really.
No.
Some of them are less drowsy, but they also typically don't work as well. All right. So on that note, let's get started with today's lecture. And what we're going to talk about today is we are going to talk about inflammatory bowel disease, IBD. And so inflammatory bowel disease is typically 3 distinct disease processes. 2 of them are related, and the third is completely separate. So ulcerative colitis, Crohn's disease, and the last one is, don't you hate it when you have a senior moment?
We're juniors.
I'm just giving you guys a chance to catch up in your writing. No.
Oh.
Diverticulitis. Way to help me out there, guys. I gotta cut that out. We can't have human professors on camera. Okay. So these are the 3 diseases that make up IBD. So when a person has IBD, they typically have one of these diseases, although it is possible to have more than one at the same time. But it's not a situation like COPD where it's always a combination of 2. It's usually just one. All right, so let's talk about ulcerative colitis first. As the name implies, there's ulcers, and it occurs in the colon. You didn't see that one coming, did you?
I didn't even think of that. I'm not reading that much into it.
The lesions are usually characterized by blood and mucus, and it's an episodic disease, which means that for much of the time, the patient will have no symptoms whatsoever. And then they will have a flare or episode where they have symptoms. During a flare, patients will have large amounts of diarrhea, sometimes losing more than 6 liters of fluid a day, and having more than 16 bowel movements in a day. Things that can trigger them include infections, stress, and food. So patients need to kind of learn their triggers and then avoid them. So sometimes you'll meet a person who like, look, I can't handle this stress today because my ulcerative colitis is going to act up. And so they like tend to avoid conflict or whatever it is that gets them stressed out. Learning which foods cause your trigger is also very important. So we're going to contrast that with Crohn's disease, which is very, very similar in that there's ulcerations of the GI tract. But in Crohn's disease, instead of being just in the colon, it can be anywhere from the lips to the anus. So you can have inflammation of the stomach, the esophagus, the mouth, or the colon. And one of the things that typically happens in Crohn's disease is that patients will have small intestine inflammation. What would you think that does to digestion? It impairs digestion. So sometimes patients with Crohn's disease will actually kind of waste away because they can't eat enough food to maintain their current weight. When that occurs, their risk of dying goes way, way up. Patients with Crohn's disease will also be more likely to have problems with not being able to absorb enough nutrients like minerals and micronutrients. Unlike ulcerative colitis, so I guess I should just mention, so ulcerative colitis, wherever the inflammation starts in the colon, it's going to continue pretty much to the end. So if, let's say that it started right here, you're going to have continuous inflammation and ulcerations all the way down to the end. With Crohn's disease, let's say you have some here, and then you have it skips, and then you've got more, and then maybe it skips again. So this is known as skip lesion. You'll never see skip lesions in ulcerative colitis, only Crohn's disease. Crohn's disease can also have inflammatory effects on other parts of the body outside the GI tract. And then the last difference is in who tends to get it. There is a genetic component to both diseases, but ulcerative colitis tends to occur in early adulthood. So mid to late 20s, 30s, that's when people tend to get ulcerative colitis. Children tend to get Crohn's disease. So typically it's during the teenage years, but it can happen earlier. I've seen cases of 2-year-olds who have Crohn's disease, although that's relatively uncommon. It's usually like, 9, 10, and then early teens. Because of the early onset of Crohn's disease, there's a psychosocial component that is important in the disease. So what's it like to be 13? Whoa, an emotional roller coaster. And what's happening around that? What grade are people in around age 13? It's like 8th grade, 7th, 8th grade. That time of your life is known as what? What part of school? Middle school. And middle school is an incredibly awkward time, right? And a lot of times you go to a new school and no one knows each other, and some people are going through puberty and other people aren't, and you're self-conscious about everything, and you're just beginning to really get into fashion, and all of a sudden what you wear really matters, whereas before it didn't that much. And some of you are cute as kids and you went through puberty and what happened? Others of you, the opposite happened, and it's just an exciting time to be alive. And then you throw into that, what happens at that time? People start doing what? Dating. So now, what is the number one date activity?
Eating.
Go out to eat. Dinner and a movie. Okay. And all of a sudden, what does it do to your social life when you can't go out to eat because you have to have a bathroom handy at all times? When certain foods trigger a flare. When the stress triggers a flare in dating and stressful. So it puts a large damper on a person's social life to have Crohn's disease as they're growing up. Now, that in and of itself is not a problem. I mean, it's a problem, but it's not a huge problem developmentally, so much as the parents, the way that they deal with it. So imagine for a moment that the love of your life, the apple of your eye, is just suffering. Suffering physically, suffering socially. What would you want to do for them? Would you want to give them a talk like, hey, sweetheart, this is the way it is. You got to tough it out. You'll be a better person for it. Or might you be like, well, honey, it's okay. You don't have to do that. We'll do something nice for you instead. How would that affect a person's development? So, Crohn's disease patients have a tendency to be thought of as somewhat self-centered and needy and maybe spoiled and whiny. And it's not because of the disease itself, it's because of the way that their parents interact with them as a result of the disease. Does that make sense? So there is a psychosocial component, but it's primarily about the developmental aspect of how parents interact with those kids. All right, so as far as the treatment of ulcerative colitis and Crohn's disease, they're somewhat similar. So the first one is behavioral. And that is learn your triggers and try and avoid them. Second is drugs. So the main drugs that are used nowadays are salicylates, which are similar to aspirin, but they're not actually aspirin, and they help to reduce inflammation in the gut. So an older drug is sulfasalazine. Now, they reduce inflammation in the gut. So sulfasalazine is one of the older drugs. As the name implies, it is a sulfa drug. So you've got the issues with sulfa allergy, and it's actually a prodrug, and it gets metabolized into something called mesalamine. Mesalamine is sometimes known by its kind of chemical nature, which is 5-ASA. Or, what's the fancy name of saying 5? More fancy than Spanish. Let's go Latin, pent. So sometimes it's called pentasa. So, 20 years ago, sulfasalazine was far more common than mesalamine because this was under patent and this was not. Nowadays, mesalamine is probably more common because it doesn't have the allergy issues. It works faster because it doesn't need to be converted, and it's generic now. So the salicylates are the first one. Then we also have steroids. You want to try and minimize the amount of steroid use because of all the adverse effects that go along with steroids. You've already learned about steroids in Pathopharm 1. We went over them again in endocrine in this course, and now you got them again. So there's no excuse for not knowing the adverse effects. Well, I mean, I guess there is an excuse, and that's that, you're a lazy, lame person who doesn't care about their... Anyway, no, there's no excuse. So, guess you should know those. And then, so a lot of times what we'll try and do is we'll try and only give steroids during a flare, but some patients will not be able to not have flares without having at least low-dose steroid. But the more steroid you give, the more likely they are to have all of those other adverse effects.
Is subsalicylate, like basement subsalicylate, is that like?
No.
No, not related at all?
It's related, but it's not what we mean.
Okay.
Yeah. All right. Then the last one is immunosuppressants. So some common immunosuppressants that would be used are the biologics, like Humira, and then also some of the cytotoxic drugs like azathioprine or mercaptopurine. And that is review from Pathopharm 1 as well. What's the question there?
I don't remember learning the second one.
You didn't.
What are they? What are those names?
I was gonna say I didn't know that.
Azathioprine and mercaptopurine.
Can you spell
Mercapto. It's a newer drug than azathioprine, and it's beginning to replace azathioprine, maybe a little bit more than beginning. So sometimes I think about replacing azathioprine with it on the drug list, but I haven't gotten around to it, so bygones. Mercaptopurine will not be on your tests, but you might see patients on it. Man, Dr. You think about, you think the reaction would be, well, thank you for letting me know I don't have to study that for the test, rather than, wasted brain power! It's not wasted. You will see these drugs in patients, so. Anyway,
Just like that.
that is exactly I can see it happening in your head. All right, any questions about those drugs? Okay, those are the main drugs that are used. And then in severe cases, you can use surgery. So we got to talk about some surgical terminology. Now let's imagine for a moment that you got a colon. Let's use multicolors. All right, so there's a colon, and let's say the patient's got an area of inflammation like this. So if you snip out the inflamed portion, what's that called? It's called a resection. So to resect means to take out a section. Now, what happens now? You got two possibilities. What are your two possibilities?
Ostomy.
Okay, so one, we're going to take this to the surface, and the patient's going to have a stoma. They're going to have an ostomy. So they're going to have colon sticking out of their gut. And you have a little bag that goes around the top of it. Does that make sense? What's the other possibility? The other possibility is that you pull this down and reconnect it together. What's that called? That's called anastomosis. So sometimes when people hear resection, they think connect the two ends together. That's not what resection means. To resect is to cut out a section. What's it called when you connect the two ends together? Anastomosis. So depending on the situation, they might do an ostomy or they might do an anastomosis. Sometimes they'll do a temporary ostomy, and then after a couple months, do an anastomosis. Does that make sense?
Why would they do that?
Why would they do that? The reason is to give, they call it bowel rest. So basically they're trying to say, like, maybe you have really severe inflammation here and then mild there. So they're trying to save the mild portion. So they're basically just letting things kind of settle down before they connect them together. Because when you connect things together, what are you going to have in order to heal that spot? Inflammation. So if things are too inflamed at first, they want to let things settle out, then do the anastomosis. There are lots of YouTube videos by people who have had these types of surgeries at young ages on YouTube, and maybe I'll send you a couple.
Do you look them up in your free time?
Yes. No, actually, I looked them up in my work time.
Oh, you might want to cut that out while you're busy.
Sage?
No, I was just wondering if this was for Crohn's disease as well.
Yes, Crohn's disease as well. The one big difference with Crohn's disease, instead of just being in the colon, you can also have it in the small intestine. So if you do an ostomy of the colon, we call it a colostomy. If you have it of the small intestine, it's called an ileostomy. So what's the lower part of the small intestine? The ileum. So ileostomies are typically on the right side of an abdomen, so over on this side, and they're smaller. Colostomies are typically on the left side, and they're larger. So you guys can learn all about what it's like to have one and change one and live with one and have intimate relations while you have one by watching YouTube. Hey, it's important for nurses to know this stuff. I mean, your patients are still going to have sex, right? How do you handle that thing? I don't know. Isn't it kind of awkward? Well, there's ways we can deal with that. Oh, okay. Yeah. So anyway, there you go. All right. Any questions about ulcerative colitis or Crohn's disease? All right. Next, we have what are called diverticulitis. Now, there are two related terms here. The first one is diverticulosis versus diverticulitis. So what's the difference between diverticulosis and diverticulitis?
Itis is inflammation.
Itis is inflammation and osis is presence of. So the presence of diverticula. So a singular is a diverticulum, and it's an outpouching of the colon. So here you've got a pocket, it's an outpouching, and stuff can get trapped in there. So as that stuff gets trapped, if it becomes inflamed and infected, that's what causes diverticulitis. So what is it that causes a diverticulum in the first place? And the answer is, we don't really know. There's a genetic component, so choosing the right parents helps. And there seems to be a behavioral component as well. We want to say that you should avoid straining on the toilet, but straining in and of itself is not going to cause diverticula. So in the end, we're not really 100% sure. Once you have them, what do we do with them? You can surgically remove them, but most of the time the answer is nothing. You should eat a higher fiber diet. We used to tell people to avoid nuts because if you open one of these things up, it looks like nut residue is in there. And so by avoiding nuts and popcorn, you don't get stuff trapped in there. But where one of the largest studies was done, it's like 100,000 people were followed for 10 years. Guess what? Turns out, doesn't matter. So the older, you'll still hear people say, well, you need to avoid nuts and avoid popcorn. But in fact, you don't. It made no difference whatsoever, the people who avoided them versus the people who ate them. Whew, I can still have popcorn. So once they become inflamed, all right, so what do we do? What do we do with ulcers? You want to maintain a diet high in fiber, and you want to basically avoid straining. Once a person's got diverticulitis, then we want to bake the patient NPO at first. And when we do reintroduce food, we want a low residue diet. What does that mean? What is residue?
Like it leaves something.
Leave something behind. What would that something behind be? Feces. Residue is what resides after whatever else is pulled out. So the residue is feces. So what you want is a low residue diet, which means not a lot of fiber. So for itis, NPO at first, then low residue diet, and then eventually they can have full diet again. That's going to be the basics, but you also may need to administer antibiotics. So NPO and antibiotics, good hydration, that would be considered conservative therapy. What are you conserving? What would you be conserving?
Tissue.
Yeah, the colon. So what's the opposite of conservative therapy?
Radical.
Aggressive, which is going to be surgery. So in more aggressive therapy, you will resect the colon to get rid of the diverticula. Does that make sense?
This is all for itis.
This is all for itis. For osis, you don't do anything. Man, high fiber diet avoids straining. Man, whatever. For itis, NPO, antibiotics, hydrate, that's conservative therapy. Aggressive therapy, cut it out. Cut it out, you guys. All right, any questions about diverticulitis? Now, the last thing we have to talk about in this little area is something called IBS, irritable bowel syndrome. Now, what is a syndrome? How is syndrome different than disease? Well, I mean, technically everything's caused by something else. A syndrome is a collection of symptoms. So, in this case, the symptoms are typically abdominal pain, bloating, cramping, and either diarrhea or constipation. Most patients will tend towards one over the other, and some patients have a diabolical combination of both. Now, there's a movie that's kind of old now with Ben Stiller and what's her name? Rachel from Friends. Jennifer Aniston. There's an older movie with them in it where his character has irritable bowel syndrome. And so if he eats spicy foods, he's got to go. And so there's a funny scene where he has to use the bathroom in her house and blah, blah, blah. So patients who tend towards diarrhea sometimes have like a sympathetic response. Like within an hour, within half an hour to an hour after they eat, they have kind of like this sympathetic response. They might get sweaty, might be a little bit diaphoretic, and then they have diarrhea. And so that's more often men than it is women. And with IBS in general, more women have it than men. So women tend towards the constipation side of things where they have constipation. So the key thing behind irritable bowel syndrome as opposed to inflammatory bowel disease is that there's no disease tissue in IBS. So if you do a colonoscopy, What does the colon look like? Completely normal. So it is called a functional illness. What does that mean? What is a functional illness? You don't like the way your body functions. Your complaint is, I feel bloated, I've got pain, I've got constipation, I've got diarrhea, I can't eat whatever kind of food without having to have diarrhea. That is a functional illness. You don't like the way your body functions. But when we do the tests, as it turns out, there's no disease. So here's a case where you have these symptoms you don't like, your life is impacted by it, but you're completely fine. No, I'm not fine. My body ain't working right. So what do you do about it?
Treat the symptoms.
You treat the symptoms. So there are some drugs you can take that will, if you've got constipation-based IBS, make you go more often. If you've got cramping-based, you can use something like Bentyl or dicyclamine. If you've got diarrhea-based, you can take drugs that will reduce your diarrhea. A lot of it has to do with finding your triggers. So if you know that spicy foods do it, maybe you avoid spicy foods. Or planning around it. So, well, we're going to have to go to the dinner a little bit early so that we have a chance to stop and go to the bathroom before the movie. You know, basically work around it. So lifestyle modifications is the #1 treatment for IBS. And then you can treat the symptoms with drugs. All right, any questions about IBS? All right, on that note, we're going to be done with IBS. Woohoo! So we're done with the digestive tract. How do you feel about that?